right, Kristen, I think we'll go ahead and get started. Is that okay with you?
Yep.
Okay, cool. All right. Hi, everyone. This is going to be a technically compromised presentation, just for fair warning. We do have Kristen here. Most of the audio is probably going to be coming out of my laptop, I guess. So pretty decent speakers on it. So that won't be too bad. So apologies for that, but we are recording. So I'll just go ahead and get things started. Hopefully there won't be too many technical meltdowns or things of that nature. And we have screen sharing functions, so that part is good. So with that, we'll go ahead and begin. So thank you all for coming for the spring segment of the Anthropology Department's Pro Seminar Series. So mostly everybody here is familiar, but just to reiterate for those who are not, so the Pro Seminar Series is a great opportunity for us to bring in people from the broader world of anthropology and the social sciences to see what's going on across all of these different subdisciplines and subfields. Just now realizing that I should probably get out of my email because we're going to hear that a lot. So I'll work on that. And today is no exception. One of the things that's nice, we can sometimes invite people from outside of the community here at UNLV. Sometimes we get to invite people that are already here or that have other connections. And today is that day. So today we are joined by Dr. Kristen Herlovsky, a name and face that is probably familiar to most of us here in the room. For those of you who are not familiar, Dr. Herlovsky is a medical anthropologist and full spectrum doula whose research explores maternal health, experiences of pregnancy, childbirth, and postpartum. So she obtained her BA, MA, and PhD from the Department of Anthropology here at UNLV, hence the familiar face. Her dissertation research explored both historical and contemporary impacts of national and global health policies on the experiences of pregnancy, childbirth, and postpartum among the foragers of Tanzania. And Dr. Herlovsky currently works as a postdoctoral researcher on the early responsive nurturing care for food security intervention at the UNLV School of Public Health. So that program serves to identify pathways to reduce high levels of food insecurity among pregnant individuals and caregivers with children under 3 years of age in the West Las Vegas Promise neighborhood. Despite being an early career scholar, Dr. Herlovsky's list of publications and awards is too extensive to list in their entirety. It's one of the downsides of doing these introductions, because I know invariably I always leave off something super important. But with that said, I'll note her co-author chapter in the 2021 Routledge Handbook of Anthropology of Reproduction, titled Alloparenting, Evolutionary Origins and Contemporary Significance of Cooperative Childrearing as a Key Feature of Human Reproduction. And that follows her co-author 2020 article in Culture, Medicine, and Psychiatry titled Postpartum Maternal Mood Among the Hadza Foragers of Tanzania, a Mixed Methods Approach. Not too surprisingly, Dr. Herlovsky's list of awards is equally as impressive, with substantial research funding coming from the likes of the Wendell Gren Foundation, National Institutes of Health, and the Centers for Disease Control Prevention Division of Nutrition, Physical Activity, and Obesity. So basically, a bunch of acronyms listed CVs is what I learned pretty quickly. Her talk today is titled, How Might Culturally Congruent Doula Care Lead to Improved Maternal Health Outcomes in the State of Nevada? So with that, please join me in welcoming Dr. Kristen Herlovsky. So we'll do a round of applause here. And take it away, Kristen.
Okay. Wow. Thank you. That's a very mouthy introduction. Got to shorten some of the titles on my papers from here on out. But thank you. I'm really happy to be here. Back to my anthropology roots. As you know, Nick said, I'm at the School of Public Health, but I'm actually not going to be speaking about anything related to my postdoc today. I'm just going to be speaking about my work as a doula. So I'm excited to be here. If you hear very loud baby in the background, he is being taken care of, but I hear him very loud. So if you hear him, sorry. So today I want to talk to you about a study that I'm doing in collaboration with the Doula Co-op. I have some of my team members and collaborators here on the call. So if at the end of the day there's questions and I can't answer them, luckily I have my team here to facilitate some of that. So how might culturally congruent doula care lead to improved maternal health outcomes in the state of Nevada? Let's see if this, okay, perfect. So maternal experience, as you know, Nick said, I do a lot of work with pregnancy, childbirth, and the postpartum period. These are significant events in people's lives. It's not just biology, though. It's always at the intersection of culture, economics, socio-political structures, what are healthcare laws, policies in place, and how do people access these resources? So when I'm doing research, I'm always thinking of this intersectionality that applies to pregnancy, postpartum, and childbirth experiences. So the U.S. is currently in a maternal health crisis. The U.S. has the worst maternal mortality rate among any wealthy nation. This is not surprising for many reasons, which I'll get into, but since 1999, the number of women who have died after giving childbirth has doubled. It's only gotten worse. And since the pandemic, it's gotten even worse. So this is truly a problem. The maternal mortality rate is how many per 100,000 live births people die. So as you've probably heard in the news a lot, there's a Black maternal health crisis because women are dying, 2 to 6 times more often than their white counterparts. And it really depends on the city and the area that you're giving birth. But national averages are at least double, but it can be up to 6 times worse for our Black mothers and birthing individuals. As you can see here, the most recent Black maternal mortality rate is almost 70 per 100,000 live births. So it's pretty high, especially considering how wealthy our nation is and how much money we spend on healthcare. And just to kind of show you again, so, things have gotten really bad since the pandemic. Is it because of COVID-19, the virus itself? Probably not. It's the systems that are in place. So, Hispanic, white, Black is clearly worse. We're talking double, if not more. And I think just important to note, I think the maternal mortality rate for women over 40 is 7 times higher than those who are under 25. And it's really bad once you hit 40. And this is true still for Black women. Black birthing individuals over 40 are experiencing worse health outcomes, but 40 is bad for everyone. And I think this is probably just interesting because the rate or the average age of first birth in the United States is getting older every year. We're still not, that's not the average first rate of birth, but since like 1999, women giving birth over 40 has like quadrupled. So this is becoming more common with assisted reproduction technologies and just people delaying reproduction later on. Are you okay still hearing me? Okay.
Good.
Sweet. So why do we have this maternal health crisis? Like, what is contributing to this? And I think that really stems back to the U.S. birthing system. The U.S. birthing system is obstetric dominated. So we're biomedically focused. It's technocratic birth. 98% of births are done in hospitals. Since the pandemic, it used to be 99, but since the pandemic, 2% of births are happening at home. So there's been, 100% increase there, but it's still it's dominated by hospital birth. And who is giving birth in hospitals? It's typically with obstetricians. And I think it's important to note that these obstetricians are typically white. This number has actually gone down. So we are seeing a greater increase in diversity of providers, but we're still looking at a system that is predominantly white, predominantly in the hospital. And this biomedical system is really focused on biomedicine, time constraints, risk management, and the medical management of birth. And that is really key here is this medical management. The average rate of induction of labor is almost 32%. And the induction of labor is basically you're going to artificially soften the cervix or dilate the cervix to get a woman or birthing individual into labor. I honestly suspect this number is higher, but hospitals and states do not have the same reporting. So this is an average, but I mean, just my experiences alone here in Vegas, I would suspect that this is much higher. And this is problematic because once you induce labor and you get a woman or a birthing person to go, you have this what we term the cascade of interventions, and it's just intervention after intervention. Not always, but this is a pattern we see. And with that, if you go into spontaneous labor and you go give birth at the hospitals, there's still this unnecessary intervention. It's actually much more rare for obstetricians to see undisturbed birth without them intervening in some capacity because they're trained to medically manage birth. And I think that's a key feature here. And so also characteristic of the United States is 70 to 75% of women and birthing people are using epidurals. And once you get an epidural, you're confined to the bed. And again, it's this cycle of, well, now you're in time. What's the risk management? You have this epidural that has risks and you're confined in the bed. So it contributes to this risk management cycle. Overall, our cesarean birth rate is extremely high. The World Health Organization suggests that 10 to 15% of births should be C-sections to save lives, we're triple that, right? And so why is the C-section birth rate so high? There's many reasons for that. Part of it is this induction of labor, the interventions that are happening. Are Americans just higher risk in general? So this C-section rate is just very high. And then I want to note, and I'll get into this, only 6% of people have a doula at their birth. Per estimates, there's some studies from like 2012 and 2015. I honestly think this number might be higher, but I think we're talking about higher in urban cities versus, rural areas. Rural areas is probably very low, if that, So this is part of that experience. And then finally, I really want to emphasize maternity care deserts, which are a growing problem in the United States. So 2.2 million women and people of childbearing age live in maternity care deserts, which means there's absolutely no hospitals, there's no OBs, no one can help them. So you have like unregulated midwifery, you have people just giving birth with, maybe certified professional midwives, but they're just out of the realm of hospitals. An additional 4.7 million have limited access to maternity care. And this is actually even more problematic with the overturning of Roe versus Wade and all these state laws. There are now residents don't want to go to these places that they won't be able to practice full medicine. And so we're probably going to see an increase of these maternity care deserts as hospitals shut down and as, physicians don't want to go to certain states because they can't practice within their scope of knowledge. So postpartum is also grim when talking about the system. We have no federal paid leave. So there's nothing in place. We're one of the only wealthy nations in the whole world who does this. There's no federal leave in place. So I think there's 13 states that mandate it and the District of Columbia, so DC. But even then, I think it's very minimal. I think it's like up to 6 weeks. So we have very little paid leave in place. And anyone here who has given birth or knows someone who gives birth, it takes your body time to heal. And it's not characteristic of our society to have support in place to help your physical body heal, your emotional body heal. I know like in France and different areas in like the UK, it's very common to have physical therapy programs, whether you give birth vaginally or via C-section. Let's help you recover and get your system functioning again, right? So we don't have these to help women and birthing people here. Our 6-week checkup is typical of the first and only checkup with your providers, unless truly something was like if you have preeclampsia or something, you're going to have more medical management. But honestly, most people are not seeing their providers until that 6-week checkup. And that's actually how we measure maternal mortality. So the World Health Organization has that 42-day period because it's a 6-week appointment when everything's fine, you're cleared for sex, go on and be prosperous in your life. So unsurprisingly, up to 45% of individuals are reporting birth trauma. Birth trauma can be from emotional things that have happened, complications, maybe your birth didn't go as expected, maybe you were violated, maybe your baby was violated, horrible things, minor things, whatever it is. This is like a growing problem all around the world. It's not characteristic of just the United States though. So, birth trauma is impacting our postpartum experiences. And so, what does this mean for mental health? We don't have mental health support in general, but it's even worse for the postpartum period. And it's pretty normal for people to experience, baby blues after birth, like up to 80% of women and people can experience this, but it goes away. It's, maybe you have some hormonal changes, you're crying, you're not sleeping well, whatever the feelings are, but it goes away without medical treatment. So this perinatal mood and anxiety disorders, PMADs, is in this first year where it's not enough. It's not just baby blues. It is actual mental health debilitating mental health issues. So that is, the experience of postpartum and more. But these are kind of characteristic features. So when we're talking about healthcare in the United States, there's this growing movement and this growing concept of providing culturally congruent care. Due to medical racism and these racial health disparities we're seeing, this concept is becoming more popular, especially among nurses, but you're seeing it in more medical schools, and physicians are basically being taught how to be culturally congruent. And it's it's in an effort to reduce bias, become more aware of inclusive cultural values, beliefs, and practices, right? Like biomedicine is not everything. There's indigenous ways of knowing. There are alternative ways that people view the world, have different beliefs and practices. And there's, Chinese traditional medicine, right? There's all these different systems in place. So how do we reduce bias to talk about, to be able to provide better care? And I really think this is important because it's focused on building trust between providers and their patients. And it's not just based on personal characteristics. Like if I see you and you look like me, maybe we have better communication. But if we don't, what can we do to minimize that gap? And when we're talking about, the Black community and racial, disparities, there's mixed research, but honestly, the research is trending that racial congruence in healthcare providers. So I'm a Black person seeing a Black doctor. They do tend to have better health outcomes, and they tend to be more honest with like the scope of their problems. The doctors, there's more, there's that ability to relate. So this is an important part of, care. And you don't just because you're racially congruent does not mean that your care will be great. There are studies, especially there's a couple like with small ones done with doulas, and racial congruence does not mean that it's the end all be all. But we do want to see a more diversity of doctors to help with reducing bias. So what does this mean for Nevada? So Nevada maternal health is very poor. It's actually kind of alarming once you sit down and look at the statistics, how poor Nevada does. There's this concept of the maternal vulnerability index, and birthing people in Nevada have a very high vulnerability to poor health outcomes. So it's, due to, for many reasons, I'll show you here, like mental health and substance abuse, physical health problems, general health care, lack of access, the social determinants of health, our physical environment does not contribute to well-being, and, our reproductive health care doesn't. And what I want to say is that surprisingly, our maternal mortality rate is less than the US. So I said it was like 23, here we have 21, but our infant mortality rate is worse. We are pretty on par here in Clark County, the southernmost part of the state with the highest population. We're pretty on par for having about 1/3 of all births are C-sections. And it's interesting because most of those, or not most, but 27% of these surgical birth is basically for people who were low risk. Like, why is it so high when the recommended is 10 to 15%? Is it because we're a higher risk population, or what is going on, right? I think our prenatal care access is actually very poor. We are suffering from a physician shortage for all things, but especially maternity care. We do not have enough providers, especially high-risk providers, for the population here in Vegas and around the state. The rural areas especially, right? Like many of the rural populations have to drive hours to even get to a hospital. So we have higher rates of preterm birth. We've been given a report card rating of D. We're like almost as low as it can be because we're worse in the US, and our preterm birth rate is very high, which is obviously very dangerous and very expensive for families and the system. And then we also have a really high Medicaid childbirth population. A half of all births here in Nevada are paid for by Medicaid. And of course, we don't have any state paid leave. So this is kind of the experience in general with in Nevada, and the rural counties are even worse. And one thing I wanted to note here was like, we're really high on the maternal vulnerability index for reproductive health care. And it's in part because like we don't have enough doctors. And for example, San Martin was a hospital here in the Southwest. They just shut down in the last couple of weeks. So now we've lost a whole hospital that did birthing, and they were one of the only baby friendly certified hospitals here in the state. So out of 3, we now have 2, and 1 is gone. And the Southwest is a huge booming part of town. So we're really missing out on giving proper care to a huge, a huge population. So the Nevada Medicaid population, which is who I will focus on talking about for, the remainder of the talk. So Medicaid has been expanded through the first year postpartum. So this is really great for trying to improve, maternal health outcomes and making sure that people can access appropriate health care for themselves and their children through that first year. The population breakdown of Nevada Medicaid is based off like historically marginalized communities. We have the highest the Black community, then the American Indian, Alaska Natives, Hispanic, white, and then Asian and Pacific Islanders. And, groupings are complicated, but this is the broad grouping. But again, this maternal vulnerability index is highest in these groups. We tend to see lower birth weights, more preterm births, higher morbidities and mortalities for moms and infants, and we see a lot more birth complications, which also leads to higher healthcare costs. So the rise of the doula, where do doulas fit into all this? Why am I talking about this? So, doulas are trained professionals who provide non-medical, continuous emotional, physical, and informational support throughout pregnancy, childbirth, and the postpartum period. We tend to emphasize, helping people achieve satisfying reproductive experiences. But, the way that a doula works is very personal. It's very individual. There's the full spectrum of care. It's not just for pregnancy, childbirth, and postpartum. Many of us work in, death doula services. Maybe someone focuses on surrogacy, abortion, adoption, birth, postpartum, menopause, fertility treatments. Really, it's a full spectrum. And so there's no national regulation system for doulas. They just take a training. Some people don't even take a training. They say, I'm a mom of 7. I'm doing it. So there's no regulating body, which is important when talking about doulas. And many of us focus on what is our scope of work. We're non-medical providers, but, we focus on advocacy. When you look at, birth trauma and consent issues in the hospital, many of us are like, I'm here to advocate and make sure that my client is listened to. We focus on childbirth education or postpartum education or lactation education. Some people focus on like sleep training, right? Like there's a very wide range of what the doula does, but it's, again, this focus on the emotional, physical, and informational support of your specialization. So what are the benefits of a childbirth doula? Because that's who we're really talking about today. There has been a big Cochrane review that came out that is often cited for what benefits a childbirth doula does. And overall, they can really assist with reducing stress and anxiety during labor. Oftentimes they're helping you before you go into labor. You know them during your pregnancy. They're a person that you know will be there at birth. And they can help you advocate for your needs. You come up with like a birth plan or birth preferences. Oftentimes when we're working with our clients, you know them. I often tell people when they're debating, do I need a doula or not? I always say well, your partner is going to be with you in the hospital or at home. You know who your, obstetric provider is or your hospital midwife, whoever, but you don't actually know who your nurse is going to be. And you don't really spend a lot of time with your provider. And I think that's the misconception. So then you go into labor and you have your doula and you have your partner and no matter what, these people will be in the room with you. And there's a sense of comfort in that, right? Knowing who's going to be there and knowing it's in your control. And so other improved birth outcomes with the doula present have included less usage of pain relief medications. So how can we get, epidural, from a cost benefit analysis, how can we get epidural use down? Sometimes the request for an epidural is lessened by up to 60%. 25% less use of Pitocin has been cited, and not the Cochrane review, but a different study. And, that's important because Pitocin has its own risk benefits, and it can cause a lot of stress for the baby. So there are a lot of benefits just in reducing, hospital services, intervention services, and you're less likely to have a C-section, and C-sections are costly. And one study found that if you had a doula, you were less likely to get a C-section by up to 50%. We help move you around. We help you talk. We help you change positions. We've been to a lot of births. That's what we do. So you tend to see also a greater satisfaction in childbirth from birthing individuals when you have the doula present. And, this can help reduce PMADs. If you are having less birth trauma, maybe you'll have a less reduction in, maternal mental health and anxiety disorders. And then I put a bunch of stars next to this asterisks because I think having a doula present at your birth in this advocacy role actually improves consent between patients and providers. And I don't have any data to back that up. This is just me waxing poetic, but when you have a doula in the room and your provider has to actually take a minute to consent you and tell you what they want to do and what the plan of action is, you practice better medicine. I think doctors, when you have a doula present, are being cognizant of what they're saying and making sure that their patient sees them and hears them. And I think that's an important part of care that hasn't actually been studied yet. Okay, so what does this mean for Medicaid? So doulas and Medicaid are a new system. There is obviously a systemic need to reduce healthcare costs. Birth is very expensive. C-sections are extremely expensive. Insurance costs with healthcare, and we need to improve maternal health outcomes, right? Like I hate just focusing on this like cost, but everything comes down to money. So what is the cost benefit analysis? And it's found that doulas can help reduce costs. So, doulas were approved as Medicaid providers in 2021, and the original reimbursement rate was $350, which is nothing. Like you would attend the birth, you would do your postpartum sessions, you would, be your doula self, and you'd get reimbursed $350. It's not a livable wage. You could spend as little as, let's say, 5 hours to 50 hours with someone, right? It really depends on what the birth is, what happens. And then in 2022, I believe it was raised to $450. And now, thank you to the lobbying of my collaborators here at the Doula Co-op, the rate was tripled and it's $1,650. And this includes, your prenatal sessions, the pregnancy sessions, attendance at the birth, and these postpartum sessions. And then on top of that, they did an additional 10% for rural doulas to try and improve, access to care. And I think this is important because most doulas are practicing and it's pay out of pocket. TRICARE, I know the veterans insurance now pays for care, but with certain organizations, but this is huge. Like most of us are just getting paid out of pocket. And if you don't have the money, you're not getting a doula. And some of us do work on sliding scales, but this is an expense, an expensive expense to an already expensive life experience. So what is the Doula Co-op? The co-op was started in 2022. It's a 501c3 nonprofit. And the goal was, to build a powerful, diverse, and sustainable doula presence to address systemic disparities affecting underserved communities in Nevada through education, advocacy, research, and community engagement. And I found out about the Doula Co-op, I think in December of 2022, and I met with one of the co-founders. I joined the co-op. They were working on this research study. And so I joined as a doula, but also with my research skills. Thank you, anthropology, for my 3 degrees so that I could be helpful here. So we received funding as part of the NIH Improve Initiative, and this was for non-academics. It's a ton of money. And it's for non-academics to build a research study. It's basically a competition competing for money. So they made it from 400 people or 400 organizations to 50 organizations. We competed for down to 15, and now we're in the top 9. So, how do you improve maternal health in Nevada? These were our goals. And if we can improve access to culturally congruent care in the Medicaid population, because this is our focus, with all the lobbying, can we see an increase in childbirth satisfaction and a reduction in PMADs? And those are what we were really interested in to make. It's not only that we were interested in that, right? But how do we make a good study? And so we are now a top 9 finalist in this NIH. We were given $150,000 to run this study. And so here it is. And I don't have any data, but I do think I have a good story to share after all that background. So, culturally congruent doula care, the missing lens in maternal mental health. Our first objective is to evaluate the impact of culturally congruent doula care on maternal satisfaction in childbirth and PMADs for Nevada Medicaid population. Objective 2, we want to train and enroll doulas in the Medicaid provider enrollment system and study procedures. So make them part of the treatment intervention. Objective 3 was we will be facilitating semi structure interviews with the doula participants. What does it mean to be a culturally congruent birth work provider? And then our 4th objective is to examine barriers for doulas in Medicaid enrollment. And that's really what I'm going to focus a lot on today. So for the birthing participants, it's originally started as a perfect randomized control trial. You're either going to be control doula or culturally congruent doula group. We are having issues with recruitment. It is very hard to get people enrolled and ready to go in the study, in part because we've had so many IRB delays, because we're working with a vulnerable population, right? So that's just something to keep in mind. So now what we're doing is you get assigned to a doula or a culturally congruent doula group. And for the Medicaid population who never wanted a doula, we just have them as our control. So it's not perfect, but it's a start. We're measuring PMADs through the Edinburgh Postnatal Depression Scale, childbirth satisfaction through the McKay Childbirth Satisfaction Rating Scale, and then measuring anxiety through the PASS Perinatal Anxiety Screening Scale. All of these are validated, all of these have been used, and we're taking it in pregnancy, and then we'll take it twice postpartum. For our doula participants, and I'm calling them participants because they're not only the treatment intervention, they are the intervention for the birthing participants, and that is separate than how we're categorizing them as an actual part of the study, because we want to be able to talk to them and do these qualitative interviews. What are their experiences with certification and Medicaid as a whole? What are the experiences with cultural congruence? And then we're also talking about potentially adding a component to just talk to doulas in the valleys across the state on why they're maybe not enrolling in Medicaid. So our doulas do not get to pick the clients. When you just work as a doula in town, wherever you work, clients pick you, you interview with them, you see if you're a good match. That's not the case here because you're getting randomly assigned. So I think that's important to know. And then they must be Medicaid certified with the managed care organizations to be part of our study. And now we're having another IRB modification because we're trying to expand it. And I'll go over this in a minute, the difference between this. But we're trying to expand to more rural areas. So now our doulas, once we get approval, will have to just either be fee for service or this medically or managed care organization. And hopefully this will improve recruitment numbers. So why is it so difficult to recruit? Part of this is because Medicaid is really complicated. You're taking people who are non-medical providers and putting them in the system, and this is problematic. And so the Medicaid essential steps are first, become a Nevada Medicaid provider, and this is that fee for service. So part of the enrollment process is $100 up front, which some people don't have that, right? That's already okay, one thing I need. And then you have to have a trauma-informed training. You have to be CPR certified. You have to be certified with a doula organization, like a certifying organization. You have to have attended at least one birth. And you also have to have a culturally competency component. So if you want to get into this work, it would be very hard to do it through Medicaid, right? So many of us that are going through Medicaid or are a Medicaid provider have already been practicing doulas. So that's a limiting factor. And then on top of that, your provider application has to get approved. But I'm pretty sure there's a waiting period, and Emily can always jump in and correct me if I'm wrong if she's here. But basically you do this part one, you get approved. It's very complicated because you're now dealing with the government system. And then once you do that, you can do a managed care organization. And the managed care organization is basically an MCO. It's a type of healthcare insurance that aims to improve access to Medicaid. They enter contracts with the healthcare providers and facilities to provide reduced costs. And so there's 4 MCOs, and you can basically certify with these MCOs, and then you will get approved Medicaid. But once you certify with an MCO, it's a 45-day waiting period to go into that contract. So it's not like you sign the contract and it's effective. You have a 45-day wait period. So as we enroll doulas into the study, if they want to be MCO certified, which they have to be if they want to work in Washoe or Clark County, which are the major cities, right? So, part one, fee for service, this works for the rural communities, but, the MCOs you have to have for the major cities. So this really is limiting for us. Our recruitment team led by Sam and Tiara, Sam in the north, Tiara down here in the south, they're having difficulty recruiting doulas. And especially doulas of color. This has been a huge problem for our study, which wants to look at cultural and racial congruence, right? And I think in part, this is because there is just not enough doulas in general in these major city hubs, but there's definitely not enough in the rural areas. Doulas are, if you remember the first study, it was 6% of people are using doulas. I think I saw something yesterday that an estimate is there's only it can't be 900, but it feels like I read something. It was either 900 or 9,000 doulas in the whole country. It is not a high number. So that's problematic. And then, all the doulas right now that are able to accept clients are white, and they're in the North. So that has been a damper on our study aims. We have a few doulas of color in the process here in the Las Vegas Valley who are trying to get certified. And they're almost, I think they've passed, some of them have passed like the fee for service, but we don't have enough people who are ready to go on the ground. And that's problematic. And it's because the certification process is really long. It takes months. It's very finicky. It sounds like if you're in the system, which I haven't done it yet, but if you're in the system, if you don't follow everything to a T, it will get rejected or you'll have to start over. It's just very complicated. On top of that, it's really difficult to work with the MCOs. And part of this is because, you know, I'll go here. So part of this is that, you know, MCOs they can't help you. So if you contact Anthem Blue Cross Blue Shield, let's say, for example, and you're like, I need help. They're like, well, we can't help you because that would help you get paid. And so it's like wonky things in the system that really are impacting, you know, the care that you're able to give. And one of the big problems with being the Medicaid system is that doulas are not medical providers. Again and again, we have to stress, people say you're not in your scope of practice, you're offering medical advice, but we're not medical providers. And maybe there are some bad doulas doing that, but for the most part, we're just individual contractors. And part of the problem with the Medicaid system is you're doing the job of many. So like, you know, a hospital, all these places, physicians that are working with Medicaid, they have people that specialize in doing different things, but the doula is doing the job of many. It makes reimbursement literally very tricky, if not impossible, because there's no doula code book. Physicians have code books. We're using physician codes to input into the system. There's no doula manual because this was just, this law is just from 2021, right? For reimbursement. So, and we can't, again, work with the MCOs because it's a weird system where like, well, if they work with us, they're helping us get paid, and that's not possible. So the Doula Co-op runs a monthly Medicaid work session to help people enroll. Thank you, Sam, for doing this. It's really great work. There's a woman who works for Medicaid fee for service, and she's been really helpful with the co-op and has tried to help enroll people. But again, it's just a lengthy, complicated process, and there's no doula manual. On top of that, we have the state and federal regulation schedule, and it hasn't been updated. So people are, you know, it was $350 originally, now it's $1,650. How do people get reimbursed? Well, it hasn't been updated yet. And so Edna Martin, a friend and local doula here of mine, she has attended a few Medicaid births and she hasn't been reimbursed more than $50. And it makes it really inaccessible. She actually gave a talk earlier, actually last week, on Medicaid and what it's like. And it's like people want to work in this population. We know that there's a need, but it's very difficult when you can't get reimbursed. People can't afford to work for free, right? And so, you know, Jen Campbell, who was the first Medicaid certified doula, I think she was up in the North. She's worked several births and she still hasn't been reimbursed for all of them. And she's had to find like finicky ways basically to get reimbursed in ways that it's like not like the system. So I think, you know, all of this is to say that becoming a Medicaid doula is extremely complicated. How do you actually support the Medicaid population and reduce maternal, you know, vulnerability and poor health outcomes when the system is so complicated? And I also want to just add that I have put here like heart work versus the system. And I think this is actually like a really important part of, you know, the doula experience. A lot of people get into it because it's this hard work. It's this calling. You work with women and families and you want to improve maternal health outcomes. Maybe you had a bad birth experience. Maybe you feel called to help for whatever reason. Maybe this is a need of your community. And so a lot of doulas work already for free, not enough wages, or they work on like a sliding scale to accommodate the needs of their community. So sometimes they don't need, you know, the Medicaid system. So I think, you know, this overall experience, which these experiences I've learned from, you know, our team members, our collaborators, Emily Barney, who's the co-op founder, co-founder of the co-op, she's a doula. You know, they've talked about like all these things that are making, you know, Medicaid very complicated for doulas. And I think the biggest highlight here that I can take away is like, it remains to be seen if doulas need to be working with insurance or should be working with insurance because, you know, this is a non-medical provider in the medical space. So how does that work? So more results, we'll find out more about the experiences of doulas, TBD in the fall. But basically our long-term goals as a community-based organization are to ask these important questions about the health and well-being of the systematically underserved communities in Nevada, whether you be in the rural areas or Washoe or Clark. And we hope that, our data can help not only doulas, but, can provide information on experiences that can help, improve policy and actions in the needs of the population. So, and if you know any doulas, we're always seeking new members. So a little plug for that. And if you know birthing people, shoot them our way to the study. And I just want to thank, the co-op, our team. We have so many moving parts for people doing things between lobbying, writing the study, taking care of the IRB, doing recruitment. So just thank you to my team here. And then I'll be available for questions. And I think we have a couple of the members here. There's questions for them as well.
Thank you so much, Kristen. Round of applause.
Thank you.
And yes, we do have plenty of time for questions. Kristen, I know you couldn't see it. You can see that we have 10, really 9 participants in the Zoom room, but I'll just turn you around a little bit just so you can see you have your participants here in the room as well.
Oh, hi, everyone.
Faces. So we'll go ahead. If people have questions, they can either, if you're online, put them in the chat. Those of you in the room, you can enunciate. And if not, I'll try to re-articulate whatever you have to ask so that we can hear and it all gets picked up. So any questions? Yeah, Samora?
Yeah, there's like a lack of diversity in doula care, and so I was wondering if there are any incentives for women of color to be able to get into it or to be able to afford to get into doula care.
And
Nick, can you repeat that for me?
Yeah, so I'll try to capture the
Thank you.
Question. So Samora was asking, are there any incentives for particularly women of color who are doing doula work or interested in doing doula work? Are there any incentives for them to get into this line of work? Because you mentioned that there was kind of a disparity, at least in terms of women of color or people of color doing doula work.
Yeah, is there an incentive to work at all ever aside from money? Sometimes it's like we have heart work. I think that's why I got called into doula work. But if you are a doula, you do get paid. People aren't working for free. And that is part of some of the issues. So if I'm a Black woman who wants to work as a doula, you can absolutely become a doula. And if someone is interested in that in the audience who wants to talk about what it's like, or what it's a process of becoming a doula, I do phone calls like that all the time with people. So if you are interested in birth work, you can reach out to me and we can schedule a talk. But yeah, I think an incentive is maybe not the right word, but if you feel called to do birth work, you can become a doula. There's no regulating body, right? You just have to pick an organization that you'd want to certify with, and then you work with the community you want to work with. It's in many ways, it's a great job because it's very independent. You work for yourself and you decide who you want to work with, but getting into the work can be very difficult. And I think in many ways, it's harder for women of color to make a community to become doulas because there's less of you, right? So I do think maybe even Tiara would be able to speak about that. I know she's told me on many occasions that the community is so small here in Vegas for women of color and people of color for doing birth work. So I do think that is a component of maybe the lack of seeing doulas of color. I hope that answered your question.
Thank you. Thank you. Other folks either in the room or in the chat? So far, it's a lot of exclamation points and positive reinforcement. So I don't see a question yet.
I actually see Tiara, though. I'll say she's put on the chat here, like her incentive was closing the gaps and reducing disparities. And I think honestly, a lot of us get into the work for that.
So I'll ask a question. How do doulas compare to midwives? I understand that midwives have more biomedical training, but do midwives also kind of act as advocates at your bedside and kind of follow up after the baby and stuff? Or do they not do that enough? And that's the gap that a doula fills.
Okay. And that just to repeat in case it didn't get picked up. So how do doulas compare to midwives? Is it a matter of the kind of advocacy that you were mentioning with doulas? Do we see that with midwives as well? Or are there other differences there?
Yeah. I think this is actually a question that we get a lot as doulas. Like, are you a midwife? No, we are not medical providers. A midwife is a trained medical professional. They can go to your birth, they can catch your baby, they can administer, drugs, they can do all these different things. I mean, depending on the midwifery certification, which is its own full talk. But midwives are medically trained professionals and doulas are not. I could literally be in trouble with the law if I attend your birth and catch your baby and claim to be a medical professional. So that's not what we do as doulas. It's literally the opposite. We're there in a support role. It's not a medical role. And midwives can serve as advocates. I think there are really good midwives out there who do that. And I think there are some crappy midwives, just like any provider, right? The big difference between a midwife and an obstetrician, for example, would just be a midwife typically treats birth as, a physiological event. They might see less use of all these interventions. And then obstetricians are the opposite. It's the medical management of birth. But I think any of providers and doulas can be an advocate. It just kind of depends on what their philosophy is.
I think we also have a question in the chat. I'll just read it out loud for the folks in the room, though, too. So you said that having a doula may improve medical consent between birthing people and healthcare providers. I just lost it. How could you study that? Do the maternal care satisfaction surveys you are using address that explicitly? So a methods question, I suppose.
That's a great question, actually. So I actually do think it's covered in the survey. So the McKay Childbirth Rating Satisfaction Scale, it's this validated survey. It's basically 34 questions, and part of it, component of the questions is did your nurses listen to you? Did your doctors listen to you? Did your husband or partner listen to you? And then it will ask a subset of questions about not necessarily consent, but I'm sure you could apply it that way. But basically, did you feel seen? Did you feel heard? I can't think of the questions off the top of my head, of course, at the moment. But it's asking about your nurses, your partner, and your providers. And it's did your doctor listen to your needs? Basically, were you heard? And I do think that's an important part of, it's not necessarily getting at consent. It's not asking, were you consented for medical treatment, basically. But if you feel listened and heard, I think it's safe to say that is probably you were felt, consented.
Thank you. Other folks, either in the Zoom room or in here? Yeah, okay.
So I saw one of the comments in the chat said something about like sponsorship and financial aid for people who are interested in getting into it. Do you guys have I guess it would be a shadowing program where you can kind of how you can do ride-alongs with the fire department, but if you're interested in being a doula in the career field, if you can shadow some doulas through the process of coordinating with pregnant people, through their pregnancy or through their childbirth.
Okay, great. And so just to reiterate, so for people who might be interested in this doulas as a job experience, is there something a program that's available for people to shadow providers, almost like an apprenticeship kind of style, or a ride along with, glad you said fire department.
Like a ride along, yeah. A police or firefighter ride along. Well, I do know in the North, they have a doula program that we do not have here in the South. And it's with Renown Hospital, and you basically become a doula and you shadow and you can attend C-sections. I don't know the nuances of it, but I know that there's somewhat of what you talked about in the hospital system. But here, in Vegas, for example, I could have you shadow me if I had approval from the birthing person. There is no reason that I can't just have you show up. I imagine I could, it would be a very bad doula move. And I don't think I would get any respect for that. But I know my first birth actually here in the Valley was I met up with a doula. I was really interested and I wanted to get connected in the system. And she was we met up, she ooh, let me figure out your personality. And she's I have a client and I think she would like you at her birth. And now she's one of my really good friends, that client. So it was a good pairing. And so I think, it's very dependent on the city, state, but most places don't have the program that Renown has. And I see Emily's hand up. So I'm just going to let her jump in and talk about that program really quickly.
Thanks, Kristen, for the whole talk and for everyone for your questions and for joining us. I'm Emily. I'm the one that she's been mentioning, one of the co-founders of the co-op and currently the executive director as well. So there's a whole lot that we have available with the Doula Co-op at the moment. I mean, we were created so that we can help folks get access. So financial scholarships and things like that are a possibility, as well as sort of this mentorship aspect, which we know is so important for doulas who are just coming into the field. As Kristen's saying, we need to have a much larger workforce, which will include having some sort of mentorship programs available for folks. And whether it's like Kristen is saying, which is a little bit more one-on-one, as a doula, you can just create those relationships individually and have someone come to a client visit or to their birth. Many doulas in the co-op have done that as they've met and networked with one another. They're now like birth teams, and now there's 2 doulas that attend every person's birth. And so you can create sort of collectives as you wish as well. But the Doula Access Program, the DAP for short, is the program Kristen was mentioning that we have up here with Renown. It is the first hospital-based doula program in the state of Nevada. And so most volunteer programs across the country that do exist, or sorry, doula programs across the country that exist are volunteer-based. What we are trying to do here is allow the doulas to be paid for their time and their work and their knowledge. And so the program is still in its early phases as the healthcare system and the hospital systems are seeing what the benefits might be of doulas and paying us for our time to be kind of floating providers. Essentially, when you walk into the hospital and you're in labor, before having gone through the process of educating yourself on getting a doula and hiring a doula, then anybody who's coming in to give birth, then there would be, just like there are nurses and medical assistants and various people on your birth team from the healthcare side, the doula would also be a member of your team, but we would be independently moving around the hospital, going to various rooms, people who needed the support, folks who are looking for certain birth experiences or might need extra support who don't have a partner to come. And so that's the idea with the program, is that we would be able to offer that. And then in that space as well, doulas can come in and get themselves experience through that process and through that program. So they can become trained as a DAP doula. They can become a member of the Doula Co-op. They can enter into this program, get trained on hospital policies, and then they can be at the hospital with another doula mentor with them, going around to all of these rooms. And like Kristen said, consenting, of course, these moms, these birthing people who are giving birth or in labor, hi, would you like doula support? We're here available to you at the hospital for free, and use us as you wish. So that's a little bit about the early phases of the program, but I will give it back to you, Kristen.
Thank you. That was really helpful. And then I see here, sorry, Nick, I just see on the chat the response about like, it's tricky since is it difficult to know what the mother knew at the time of their birth. I think you're hitting really important points on consent in general. It is extremely difficult to consent people, especially when they're in labor, especially in unmedicated labor when you're in the thick of it. So I think I don't have a good response on this other than like, oftentimes when I'm working with clients or people I know, you try and prepare them for a bunch of different scenarios at home so that when you go to the hospital, if someone says like if they never wanted an episiotomy, which is like a laceration when you're giving birth, if they are vehemently against it, when their provider is like, I want to do this, we can say like, she does not want to do this. We can do things in advance, but it's never full consent, right? Because your consent can change in the event of something. So I do think consent is very difficult. And I do think, I do think there's a lot of nuance to the response of that.
Other folks, questions in the physical room, the Zoom room? Yeah,
I guess I'll just also ask in terms of methods, and the kind of data that you plan to collect or hope to collect because you are unregulated. Is part of the methods also considering the downsides of being unregulated and not having a cohesive training program or handbook? Is that going to be part of the methods too?
Yeah. Were you able to get that, Kristen, or would you like me to?
I think you're asking about like the methods for the doulas being part of not having any regulation, right?
Right. If part of the data gathering that you are in the process of doing, because this all seems fairly new, also includes maybe the downsides or possible negative outcomes because you are unregulated and there is no cohesive training program.
Yeah, I think yes and no. I think if doula is actually within their scope of not being a medical provider, not giving medical advice. I have mixed feelings on regulation. On one hand, being trained and certified through an organization, there are several out there. There are many out there that's grown in popularity. DONA is like, the original, like people love talking about DONA, CAPA. There's a bunch of different programs. I trained through DTI. There's different options. So most doulas tend to get certified through an organization. It's just that it's not nationally regulated. And most of the time it's like these training sessions are just that. They're training sessions. They ask you to read books. They ask you to attend a birth, to talk about it, whatever it is that you're training for. That's it. But on the flip side, if you're not working and giving medical advice and you're just a support person, I mean, does it matter if you were trained as long as the person feels supported, right? So I think this is a tricky aspect of that regulation. Now, on the flip side, in questionable situations like free birth, for example, is a very popular, not very popular, this is a very minority of the population that's doing it, but basically free birth is a rejection of all things system, no medical providers, not a midwife, not an OB, no one is going to attend their birth. But there's a lot of doulas who attend free births. And this is when we get into that tricky aspect of like, what is medical care provider? Like for me, for example, everyone has the right to do whatever they want with their body and have a free birth. I would never attend because if something happens to that baby, I'm going to look like the most knowledgeable person in the room who is able to give medical advice, right? And that's not the case. So I stay within my scope. I think most doulas are staying within the scope of not having medical, advice, but I do think it'll be interesting to see if it does become a national regulation as more states enact this Medicaid policy. Yeah, sorry, that was a long-winded answer.
Folks, yeah, Carrie again.
So I'm thinking, because you said when you become a medical provider, that's basically the transition to being a midwife at that point. So I was wondering if there's like a mid-ground level. I'm thinking like a nurse practitioner. So when you're in between a nurse and a doctor, essentially, if you could be in between a doula and a midwife, because just like, I guess I'd like to know where that cutoff is, or if there's any like gray area.
So basically there's levels of midwifery for certification. There's people like, like the term like granny midwife or like unregulated midwife. It's people who did not train in the system, but have attended many births, have a bunch of knowledge that's not in the system. Then there's certified professional midwives who are like getting trained through maybe a midwifery college or, using like the National Association of, I don't know, it's like midwifery something. Basically they use like the NARC system to become regulated because they take a test. And then there's RN nurse midwives who are APRNs. Midwifery has nothing to do with being a doula. Doulas, again, it's that scope of practice, which is no medical. And some, I know people, like I know a physical therapist here in Las Vegas who did doula training because she wanted to be a physical therapist and learn how to better support birthing bodies in physical therapy. And like, when issues arise in the hospital, she wanted to be able to speak better about it, speak to their issues. But she is a medical provider first and foremost. Does that make sense? So like a midwife could never just be a doula in the hospital. Now at home, I do know midwives who will take clients, like home birth midwives actually, who take clients that are doula only. But it gets messy because sometimes they act as like they'll to do cervical checks. I could never do a cervical check. I'm not a medical provider, right? So I think, I don't know. I think it's complicated, but it's just midwives and doulas are not the same. They're actually completely different tracks of care.
You have one more minute if anybody wants
Okay.
to tweet in one more question. We'll try to be respectful of everybody's time with that. So another round of applause for Dr. Velasquez for joining us today. Much appreciated.
Thank you so much, everyone.
Thank you, Kristen. Thank you to everybody who was able to join us virtually as well. And yeah, we'll, with Kristen's permission, we'll go ahead and post the talk a little later.
Okay. Thank you, Nick. All right. Bye, everyone.
Good one.